We're very pleased to have with us today Dr. Brien Smith, who is an epileptologist with Spectrum Health and the immediate past chair of the National Epilepsy Foundation. Dr. Smith also serves as co-chair of the Department of Clinical Neurosciences and Chief of Neurology for Spectrum Health Medical Group in Grand Rapids, I might add. I had to bring that plug in. He is a leading national expert in the management and care of epilepsy. Dr. Smith, give us a little bit about information about yourself and a brief overview of your background and your experience with epilepsy.
Well, thank you. Good afternoon. I know it's been a long day, and those of you who have stayed for the 3 o'clock hour, I do appreciate that. And a little bit about my background. I am a Detroiter by heart. I grew up on the west side of Detroit and stayed here most of my life. I was at Henry Ford for 20 years. As a youngster, probably at a younger age than everybody recognized, but I did have seizures, and that kind of went undiagnosed for a while. And I remember the first time I had a major seizure in the high school parking lot. I first started realizing how little people knew about seizures and seizure intervention. As they were wheeling me down the gurney in the ER and I had some unusual behavior, they all just imply that I was on drugs, which I wasn't, at least at that time. And that led to subsequent diagnosis. But even over the years, when I got into medical school and looking how patients with seizures or epilepsy were being treated, or kind of that stigma was pretty evident. Even when I would round with others who didn't necessarily know my history and some of the conclusions that were made based on the history or the behavior that was seen, and that wasn't right. And part of what we all need to do is help educate the rest of the public. I subsequently found out why I had seizures, because it was related to a brain tumor that was subsequently removed by brain surgery and have been fine for quite a long time. So that was probably part of my interest in pursuing this career path, and it's been a lot of fun. There's been a lot of very interesting stories and difficult cases, and a number of people in the room I know from the past. And I hope that I can answer some of your questions. What I will say is this is kind of a waiver, because a number of the physicians who have been here at this meeting I do know, and some of you are being followed by those physicians. And you may ask me a question that the answer I give is different than what is happening with your care right now. That doesn't mean they're wrong. Remember, there are lots of opinions out there and they can vary. And there's like 28 different seizure medications right now. And what I picked to be my first, second, or third may be different than your physician or your other colleague that you've seen in the past. So keep an open mind as we talk about various situations and what you would do or what I would do or what your doctor has done, and there's not necessarily a perfectly right or wrong answer. What you learn in this field is every brain is different. Seizures come in all sizes and shapes, and you have to really keep an open mind in that whole field. So thanks for letting me introduce that.
All right, thank you. Now, Andrew is going to be coming around with a mic, and this is your opportunity. This is why we call it the Adult Open Forum. This is your opportunity to ask questions for Dr. Smith regarding epilepsy in adults. And so, Andrew, wave the mic, and if you have a question, raise your hand. Looks like you're going to be busy. Be patient.
I wanted to know, since I have epilepsy and I'm 38, and they've changed me from phenobarbital, and I've been taking phenobarbital probably ever since I was 10. Is my body going through like a tizzy or whatever they call it? Because they took me off of one and then put me on Vimpat, and it's like for the first month or whatever, I felt like I've been having a panic attack or something. And will that get worse every time they want to change my medication? Because let's say like my seizures aren't, stopping or whatever. But if they want to go up my medication again, is my body going to go differently?
Yeah, I would agree. You're definitely having a brain or body tizzy right now when you come off phenobarbital. Phenobarbital has been around for almost 100 years. It's a great drug. Remember how I talked about there being 28, 29 different seizure medications? There's really not one medication that we clearly know is better than the other. If you look at all the trials that have been done comparing this drug to this drug, a lot of them have a very similar ability to stop seizures. The thing with phenobarbital is we know it works. The problem is the side effect profile with phenobarbital. I mean, long-term, when we look at phenobarbital, we know you're at risk for osteoporosis. There's a significant risk of depression. When they've done studies in children, they know that they don't perform as well academically in school. So even though it's a very good drug, it's rarely ever number one on the list anymore because of the side effect profile. There's a lot of new drugs that work just as well with less issues. The problem is phenobarbital is not easy to take away. Phenobarbital, dilantin, and some of the benzodiazepines can be very difficult to take away. Your brain has kind of got used to them. And you can get in a lot of trouble if you take them away too quickly. You can have some of the worst seizures that you're ever going to see. And taking away phenobarbital may take a year. It's a very prolonged process for some people. And even if you do the most conservative taper from phenobarbital, you could still run into problems. I can tell you, I've been down that road with a few patients where we did the most conservative taper and they had coverage with another medication and we still had to go back to phenobarbital. Say that again? Well, the body was responding, and in the sense that that brain had gotten really used to phenobarbital and nothing was providing that same amount of control like phenobarbital was. So even though phenobarbital has its issues and will rarely ever be considered a first or second drug as a new patient comes into an epilepsy or neurology clinic, you have to realize that if you've been on it for a while, it's not necessarily the easiest thing to get off.
Next question.
You said you had a brain tumor. I also have a brain tumor. Is that what the brain tumor causes epilepsy?
Yes, you know there's lots of different causes for epilepsy. So if the term epilepsy just means recurrent seizures because you have an electrical short circuit of the brain, if you think of almost anything that could injure the brain can cause seizures. So whether we're talking head trauma, brain tumor, stroke, brain infection, and then we have lots of epilepsies that are genetically inherited. You've gotten a trait that was passed on in the family line, and you've got that same risk now to have seizures. But brain tumor clearly can be a risk factor for the development of epilepsy. Interestingly, for brain tumors, some of the more benign, slow-growing brain tumors are more likely to cause seizures than the more malignant, faster-growing tumors. And part of that is we slowly see something growing and stretching the brain cells and rearranging the network. You lose that kind of balance of electrical activity, and that's what causes the seizures. So, yes, brain tumor is a common cause for the development of epilepsy. Well, inside or outside the brain tumor, that's a bit more debatable. Depending on what type of tumor you have and how it grows into the brain, or the brain ends up getting deformed around the tumor, it could be one or the other. Typically, if you take a golf ball brain tumor, the seizures are actually coming from the outer border of that brain tumor where the regular brain is being stretched and kind of injured. So not necessarily from within the tumor, but there can be variability depending on what type of tumor you're talking about.
So epilepsy can be inherited. Can it also be genetic, where a parent or somewhere in the family has a gene and
Yes, so I know I was pointing there and you had someone back there too. No, that's okay. So you had mentioned, just to repeat your question, epilepsy can be inherited, and is there a gene that can be passed on? Yes. I mean, if we look at the epilepsies, almost half of them we don't know the cause and we assume, well, there is a genetic predisposition. When I go back 20 plus years ago when I did fellowship, we knew very little about the genetic causes for epilepsy. And now we've labeled a number of them where we found out, well, because of this gene, your sodium channels aren't working very well, or your receptors aren't working very well. And then how are they passed on in the bloodline? So we only know a very small amount of them, though. You look probably in another 5 years, we're going to have a number of other diagnoses that are related to that genetic predisposition. One thing you should remember, though, is when we look for risk factors that cause epilepsy, we have patients, well, it's not a stroke, it's not a tumor, it's not head trauma. We don't know why. And that isn't necessarily going to be easily answered. In many cases, there still may be this genetic predisposition, we just can't identify it. And in some, I always mention this to patients, you may be a mutate. Don't take that personally, but your genetic code is always changing, and for some reason, you may have a genetic form, but that wasn't passed on. It just happened when you were in development, and that's the problem now.
On Tegretol, does that, if you want to reduce Tegretol, does it have the same effect as phenobarbital?
So the question about tapering medications, Tegretol versus phenobarbital, all the seizure medications can create a problem when you're taking them away. So when you've got a medication being removed and maybe one being added, you kind of want to be sure that second drug has gotten up there to provide some protection, because the brain has gotten used to your medication. And anytime you take away a medication, that carries a little bit of a risk. And your physician should tell you, anytime you change the drug combination, you potentially have a risk. So we want to try to do some type of process or plan where you do have coverage. If you look at the number one reason why people end up in an emergency room with seizures, it's because they've missed medication. Maybe that's just one dose. Maybe they're late by 2 hours. So we already know that there's that risk there. And then if we're coordinating you coming off a medication, we know we have to be careful. Now, Tegretol is not nearly as complicated as phenobarbital. Phenobarbital and dilantin and the benzodiazepines like Klonopin or clonazepam are a bit more difficult than some of your other standard seizure medications.
How do you keep the medicine from going outside of the box to cause a seizure versus keeping it inside to vocal the seizure?
How do you keep it inside?
Yes.
Inside where?
Inside where the cell is.
Oh, okay. You mean in the brain specifically? Yeah.
Where it won't jump out of
Yeah.
having another seizure because of it supposed to be right there instead of out.
Well, you got to remember that, unfortunately, when you take a seizure medicine, it's like taking any other medicine. It goes in the blood, then it goes to the brain. So if I have left temporal seizures, I would love to just take a seizure medicine that's only going to go to my left temporal lobe. I don't want to bother my right temporal lobe and my parietal lobes and all that, because remember, seizure medicines are what we call central nervous system depressants. They quiet the brain down. So ideally, I only want to quiet the part of the brain that's causing the problem. But it doesn't do it that way. Unfortunately, the medication goes everywhere. So when we balance how much medication we're giving, yes, we want to stop seizures, but maybe the only way I'm going to stop certain seizures in certain parts of the brain is if I give so much phenobarbital, the patient won't call and complain because he'll sleep 23 hours a day, and that's not our game plan. So you need to realize that no matter how many medications you're on and what dose you're on, there are certain types of seizures that may not respond. These little funny feelings that you get, the auras, those can be very difficult to stop. You can have brain surgery and you won't have any more of the bigger seizures, the grand mal or secondary generalized or the complex partial, but you still may get that funny little feeling every once in a while. So, what you do to keep the medicine is you just got to be adherent. You have to take it when you're supposed to take it. That's pretty much all you can do. There's really no way to funnel it to one specific area of the brain more than another, unfortunately.
Yes, I've had some sodium issues on one drug where it was down around 118, and after being hospitalized for a while, they sent me back home at, I think, 129, 130, and it took weeks, though, to get it back up to like 131 or 132. and I've been changed on meds. And my last set of blood work showed the sodium was back down to 130, which is slightly below. Now, am I supposed to be concerned on this, or just keep a real tight eye on it? And the drugs I'm taking, they're working magnificently.
Yeah. Unfortunately, there's a couple drugs out there, Tegretol, carbamazepine, trileptal, oxcarbazepine, which commonly can cause hyponatremia, or your sodium level dropping. And if you look at a lab sheet, most sodium levels say 135 to 145, and people on those medications are frequently down around 130 or 128, and not that you completely ignore it, but I can tell you that I have completely ignored it over years in many patients until it gets lower. When you get down in the 125 or below, 120 tends to be a real, hey, I need to worry about this, because remember, your sodium level, sodium is an important ion in the channels of your cell membranes. And once your sodium gets too far out of whack, not only will it affect brain activity, but it could affect other areas of the body, like your heart and things like that. So, am I worried about 128, 129? No, but you do need to follow that as long as you're on that medication, because how the medication affects the brain and how it saves sodium in the body is something that you kind of keep your eyes on. Unfortunately, no quick, easy fix. Some people have talked about fluid restriction or taking salt tablets and other things that you can maybe do some quick fixes. If the drug's working, you just really want to follow it and not necessarily have to change if there's not a problem from it. He needs to walk a little faster, doesn't he?
Okay. I want to have you talk about memory loss and being able to write things and not being able to spell things. I have a real problem with that. When I want to spell something, I can't spell it anymore, or you hear something on the phone and they give you a telephone number and you can't write it, and you have to repeat and repeat the call, the numbers and everything. You can't do it anymore. And when I want to spell a word, I can't remember how to make an S or spell the word anymore. In the memory, too.
Unfortunately, with epilepsy and recurrent seizures, memory is probably one of the biggest issues that tends to suffer over time. If you say someone's epilepsy started at age 10 and you look at their memory scores, a lot of times they will drop over time, because seizures are short-circuiting your brain, but specifically a lot of people have epilepsy involving your short-term memory circuits called the hippocampi. And these, you got two of them, one on each side in the inner part of your temporal lobes. And as seizures occur, you can actually lose brain cells in those regions. When we look at someone who's a good surgical candidate, we expect to see one of those temporal lobes show scarring or actual shrinkage because there have been brain cells that have been lost. The issue of spelling, a lot of that depends on where your seizures are coming from. So, for example, people who have seizures more on the left side of their brain, it's not uncommon to have issues with language and spelling and word recall, whereas on the right side, it may be different things like recognizing pictures or being able to follow a map or doing math and music and things like that. So the guess is here that these are problems with the temporal lobes causing memory, and there might be a little bit more involvement on the left side than the right side. I missed you both there.
Missed you
There,
again.
he's getting into the, maybe we should get a second microphone out there. I think he's going to have a heart attack here.
Yes,
I'll
is
go
there
out.
anything new in research coming out with the LGS and any new treatments for LG, or specifically tuberous sclerosis?
So you brought up two major different pathologies there. So LGS is Lennox-Gastaut syndrome, which is a fairly severe form of epilepsy. And then tuberous sclerosis is a different issue that has a genetic component that can cause seizures because there's some changes in the brain. As you know, we'll start with TS. TS has had a drug called vigabatrin available, and it's a very unique drug, but it has issues with it because it can cause visual field loss. There's nothing new specifically with a TS label on it right now. As you know, there's 2 or 3 new drugs coming out that we know are coming. They're not here yet, that have different mechanisms of action. but no specific highlight in the TS population that I've heard of at this point. A number of the new drugs that have come out, Onfi, Banzel, have the LGS title on them. But remember, we run into this problem with insurance companies sometimes. You got a great new drug that comes out and it has a wide spectrum of action, which means it works with all different forms of epilepsy, but it only gets an approval for LGS or Lennox-Gastaut. Well, we know that it can work pretty well in some other forms of epilepsy, but then when we prescribe it, the insurance company says, oh, no, we're not going to pay for that because it only says the FDA has approved it for LGS. So there are some challenges to that. Unfortunately, the two other drugs that are coming out right now don't have a specific LGS indication. They're both for partial epilepsy. And as I said, nothing specifically that I'm aware of with a TS focus right now.
And Andrew, I'm going to help you out up here.
Is there a device that you could use for stopping you from slipping out of a chair in the workplace that you know of? And do you know, do people build up resistance against drugs that worked for them? Epilepsy drugs that do work for them, do they build up a resistance and over time?
Yeah, some can definitely build up a resistance. I mean, a lot of people get frustrated when the driving restrictions are 6 months because they want to drive sooner. And let's say you started a new drug, and guess what? A lot of times we see what's called the honeymoon effect, where you do really well for the first 3 or 4 months, and then boom, the brain figures out a way to get around that drug. So you can call that resistance. There are also certain medications, specifically the benzodiazepine class. And I am not suggesting this is a drug you should be on regularly, but for example, Valium works really good for seizures in the emergency room. You come in and you get an IV and it stops the seizure. Well, why don't we use it all the time? The problem is you get addicted to it. You're going to be a bloody drug addict. I mean, 5 milligrams works for a while, and the next thing you know, you need 10 milligrams and 20 milligrams, and we're halfway according to the sign. So that's what you got to be careful of. The issue of a device preventing you from sliding out of the chair at the office, I ain't got nothing on that right now. I wish I did. There is something that just came out called a smartwatch that I just saw by the internet, which can monitor some movements and maybe send a signal to someone. And I know a lot of people are looking at various devices that you could wear that could send the signal that you're having a seizure, or I know all of you would love to have something that would pull your car off to the side of the road and, you wouldn't have to have driving restrictions, but those are not here yet.
Hello. Last December, I had the surgery that we've talked about before. I'm feeling much better. I'll tell a friend here. After that, yeah, I had a little memory, even nowadays, things. But I live home alone. My wife had passed away. And my daughter's always asking me this or that is in my question. But if I got to clean something in the house or I got to do something, well, I know where everything is, but I don't even have to remember the day, where stuff's at. Too many times I don't write the name down as other people have said. In the meantime, I'm been on 3 epileptic medicines. I returned to them, 9 years ago, plus or minus. I had epilepsy as a very young boy, and until I asked my parents midway through high school, could get them taken off. I felt, I'm all through with this.
Yeah.
But it came back as an adult. So it bothers, on those 3 epileptic medicines, I have split them up since any one of them is twice a day. I take one by itself and decided to take the other 2 by themselves. I don't have to feel this all at once and not be able to do something. Do they still do their thing without having to take all 3 of them at the same time?
Yes. So every drug that you're on should be dosed in a way that you have a fairly smooth blood level for 24 hours at a time. Okay? That's why some drugs you have to take once a day, some you take twice a day, some you take 3 times a day. But remember, your body and your brain aren't supposed to be on drugs. So when you take a drug, it's like putting a backpack on and putting 10 pounds in your backpack. When you have to take a second drug, it's another 10 pounds. So you're kind of walking around with some weight that you normally shouldn't have to have. And when you take 3 medicines all at once, unfortunately, sometimes those levels all peak at the same time. And whoa, you know, you look like a drunk, you're blurred double vision, you're tripping over stuff. And that's why when you talk to your doctor, you have to sometimes stagger medications so these don't all peak at the same time. I mean, the goal is we would all love to be on just one medication without side effects and be completely seizure-free. We know we can't all get there. You got to be a little careful. Yes, as we add medications, there's one that works one way and one that works another way, and maybe that's the perfect combination. But that's not always easy to find. And remember that these drugs can actually compete with each other at times. So this is where you have to have lots of discussion with your physician. One, how well is my regimen working? But two, how many side effects am I having and when am I having them?
Hi. Did you used to work at Henry Ford?
Yeah, just don't say anything. My parole officer's outside, so.
No, I guess what I wanted to say or ask is if the neurology field has looked into the possibility that negative and positive energy, which definitely affect the brain, can have something to do with just what's going on around you, perhaps in a home. You know, a lot of homes have dark secrets. And the reason I ask that is because I made a conscious decision in first grade that I would do everything I could not to hurt another person. But what happens is people, not consciously, see that and they abuse it. And so I'm wondering if that negative energy, it has to go somewhere, could cause.
Yeah, I mean, the issue of negative and positive energy and how you look at that and what you feel that is or isn't. What we do know is stress, and most people would say that's partly correlated with negative energy, can lower your seizure threshold. So I would love to say you all should have a life without any stress because then you're going to have less seizures, but we know that's not an easy task. But you should try to identify the things that do reduce that because stress clearly can lower epileptic seizure threshold. And as you heard from the last discussion on psychogenic non-epileptic seizures, that's a whole other issue too, how stress can come into play with seizures in that space too. So unfortunately, there's not a lot of evidence or data out there. I mean, when you try to prove something in our scientific medical world, you have to have things you can clearly measure and report at 1, 3, 6, and 12 months, and positive and negative energy is not a very easily measurable concept.
Yes, Dr. Smith. I just met a relative of mine who has 5 brain tumors. He had one removed. He was having seizures. He hasn't had seizures for 6 months. He has another one in the brain, non-removable. Could he continue afterwards, because he's going through chemo, have more seizures with the other tumors?
Yes. The brain's always changing, and especially if you have more than one tumor. Even if you only had one tumor, there's changes there. Remember, your brain is a constantly changing organ. You're born with the most brain cells you're ever going to have. Day 1 after birth, that's the most brain cells you're ever going to have. So every day, we're knocking off some brain cells. If you drink too much alcohol that day, you knocked off more brain cells. The point being, your brain is always changing. You can have someone who's seizing away 5 years in a row, and all of a sudden they just stop seizing. Why was that? You didn't introduce a new drug, but there are these subtle changes that occur. Sometimes those changes occur in the right direction. Unfortunately, sometimes they go in the wrong direction.
Hello. I've been seizure-free for 18 years. Tegretol and Neurontin, 200 milligrams. Do you have any idea what or why? I mean, this is a good thing. How do you go from 40 to 0 in a year?
From what to 0?
I went from 40 seizures to 0 seizures in 1 year, 18 years seizure-free, taking Tegretol and Neurontin, 200 milligrams. Do you know what may have been the cause and effect or non-cause and effect of what I was on prior? I was on several meds prior.
Well, like I said, every brain is different. What works for you or what's worked now for you, I could pick 5 other people over here that it doesn't do squat for. It doesn't help them at all, okay? Because every brain's different. The scarring, the electrical abnormality is different, and how these drugs work is different. I'd love to answer your question because it's a good question, but I'd be kidding you if I had any type of answer there. For some reason, we do know that some combinations are synergistic, which means they work together and they actually give you more of a positive response when they're used together. And my guess is that you had some typical brain changes occurring on its own, and then you got to that combination that ended up being the perfect mix. But that's guesswork.
It may be an accident of commercial real estate, but I know that the Alzheimer's Association, Epilepsy Foundation share the same building there on 10 Mile and Telegraph. A larger question, though, is there any evidence that having epilepsy makes a person at any stronger risk for having Alzheimer's?
It's a great question, and a question I don't have an answer to. You would think, well, maybe, but remember, these are different forms of pathology. What's happening in the brain with epilepsy isn't the same thing that's happening in Alzheimer's disease. We do know that if you have Alzheimer's disease, you're at higher risk to potentially develop seizures. We don't know that if you've had epilepsy, you're at higher risk for Alzheimer's disease. Part of that is what you really need to do to answer that question is take a population of patients and follow them for many years, and no one's done that at this point. Is there a possibility? Sure there is, but there's nothing in the literature right now to support that yet, that I'm aware of.
You know, I don't hear a lot of discussion about auras. I normally get them, but I have some indication I'm getting it slow. I can feel it coming, and I know I got to sit down. Okay, and I'll sit down, take it easy, and rest. Pretty soon, it'll go away. I'll get a headache. Well, one day, I was sitting down. I've been working at my desk at home, and I was doing some work, and all of a sudden, bang, my brain got hit. It must have been an aura. And I looked at it. I didn't know what I was doing. It was like a blank. And I looked at a piece of paper, and I didn't understand what I was doing. Well, I looked at it, maybe I refreshed my memory, and I couldn't understand one thing. It was like a complete blank. I couldn't understand anything. That was the first time that ever happened to me. Yeah.
So what I would say is you just didn't have just an aura. Remember, aura stands for a simple partial seizure. That means only one area of the brain is short-circuiting, and it's staying on one side of the brain. So, I mean, I could be having an aura right here with my hand going like this, and it's a simple partial seizure. It's a seizure in my motor strip, or it could be a funny feeling in my stomach, which we also call an aura. But it doesn't progress enough to the other side of the brain where I lose contact or lose memory or I'm not with the program. You got to the point where wow, what happened here? You weren't with the program. So now it's no longer just called an aura or simple partial seizure, it's a complex partial seizure.
Yes, I'd like to ask, there's a new study now where, you know, people have been telling me about the marijuana pill. No, I just want to find out about that and how it would affect people with seizures.
Right. Yeah.
You knew that one was coming.
Yeah. I really want to do that study. Yeah. I mean, well, we all know that there's lots of literature that suggests marijuana potentially could be effective in seizures. The fact that it was voted and approved here in the state of Michigan has no scientific merit, to be quite honest with you. You can't really have the lay public voting on a medical issue. You really should go on scientific data. But as you know, there's rat and mice models that suggest THC and other things in that concoction can help control seizures. Marinol is the name of one of the pills that's been available, and you're right, we need to have a study that's prospectively done that shows it truly does work. I mean, you can imagine if you're trying to do a marijuana study and you need a blinded placebo arm, I mean, people know when they're smoking marijuana or not, because I think there's some other effects, at least I've been told. I have no knowledge of that. So it is a study that I think we're all waiting for. And my feeling is, at least from my experience talking with patients who have, I think it is beneficial to some. You do need to remember, though, there's also anecdotal reports of people who got worse with going in that direction, too.
The question that the gentleman had back there on Alzheimer's, can it affect somebody like us along with seizures too? Because that's the other question I hear. Yeah, you have seizures, but no, you don't have Alzheimer's. How can that? Because I've been in the same boat the lady has up front there, where I forget what I'm doing or where I'm at.
Right, but memory dysfunction is not Alzheimer's. Memory dysfunction can be part of Alzheimer's, but remember, Alzheimer's has plaques and tangles. We know that there's a different pathology than what we're talking about with epilepsy. So memory loss and memory loss can clearly have two different reasons. Now, I can't tell you that the perfect study's been done over the last 30 years that completely eliminates that process. Because remember, if you take a bunch of us, there are some of us who are going to have Alzheimer's, whether we have epilepsy or not. So you need to have a study that puts some clarification to that question. Right now, though, there's not clear-cut data that says, yes, you have epilepsy, you will have Alzheimer's.
What I would like to know is that I was put on phenobarbital and Dilantin, and for like a couple of years, I went without having seizures. I guess they call that the remission, right? Okay. After they started, switching me off of medications and putting me on different ones, then it was like my auras started being almost as bad. I have grandma seizures, but it was, how can I put it? I was having more auras, at least probably 5 a day, 6 a day. And when they was asking me, well, when was the last time you had a grandma seizure? I'm like, well, I haven't had a grandma in probably a month, but I'm having auras every day, sometimes 5 a day, sometimes 6 a day. I remember I had to go home with the EEG that they take home or to use overnight for 48 hours. I had 38 of them.
Yeah.
In 48 hours.
Right. So yeah, when you change, you can relight the fire. I mean, something that's been controlled, you take away what's keeping that controlled, you can start having little issues. Now, when you look at your case or anybody else's case who's switching, let's say they're having one complex partial seizure a week. I've had patients where I've switched them to a different medication, and now they're only having one seizure a month. Clearly an improvement, but that one seizure they're having is now a grand mal versus a partial seizure. So we can't just look at numbers. We have to look at, one, how many you're having, what type of seizure, and how do you feel about it? I mean, yeah, you're not having any grand mals, but if the 35 auras per day are driving you crazy, that's a bit of an issue that you have to then take to your clinician. Right. Yeah, and this is where you have to be part of that decision-making process. I mean, I can show you tons of literature that says, no, you don't want to be on phenobarbital and Dilantin long-term. But if you make every effort to make that switch and it's not successful, I mean, this is your life, and you know what you're facing every day, and as long as you understand what goes along with being on that, then that's not necessarily not a possibility or not an option. And you got to decide what your good day is.
I know that sometimes when children go through puberty, they outgrow it. Now, can they just like be 20, 30, 40, and all of a sudden the epilepsy will stop?
Yes.
Have you ever heard of that?
Yes. So there are certain pediatric epilepsy syndromes that you will grow out of, okay? But there are also a number of epilepsies that start right around puberty because all these hormonal changes. remember, there's over 40 epilepsy types, so I can only generically answer the question. But yes, you can have someone who has seized before, is under control, goes years without a seizure, and then boom, something happens. It doesn't mean that there's necessarily a new insult or problem to the brain. It's just electrically, it's gone from being stable to now it's not stable anymore.
Anyone else have a question? Raise your hand. Okay, I'm going to go back here, over here. Okay. We'll go back here.
My question is, now why do women during their menstrual cycle go into having epilepsy during that time? Is it because of the hormones or what?
Yeah, it's a hormone issue for the most part. I mean, progesterone is a good thing. Estrogen is not a good thing for seizures, and right around the time of the period, the estrogen goes up and the progesterone goes down. That's a bad ratio, and that's why a lot of women have these catamenial seizures or catamenial predilection for seizures right around that time. And that's why there's been some studies looking at progesterone lozenges to try to kind of beef that up a little bit. The study was done, it worked for some people, but it wasn't burning results from that. But you'll have some people who are on progesterone for an additive effect to try to stop seizures around them. Oh yeah, lack of sleep. Remember, things that cause seizures: sleep deprivation, stress, menstrual periods, alcohol, missing your medication, things like that. Okay? So you got to try to avoid those.
I have a question. I'm going to write this down. Sometimes a lot of times, it's easy to forget something. And it isn't just like take your medicine at 9 o'clock. I have this little alarm that'll remind me. But what if it's something that, like, I'll ask my friend here, what time is Elaine coming over tomorrow? She'll tell me 11 o'clock. 2 minutes later, what time's Elaine coming over here tomorrow? Any suggestions on how to help me with my memory that way?
That's a challenge, because if you know how memory circuits work, when you bring in information, you need to have a kind of a processing it to put it in your memory banks. And unfortunately, with some people with epilepsy, the way the memory circuits get involved, that doesn't work very well. She would have to tell you that same thing. Remember this, and then remember this. And sooner or later, you'll process it enough where it will land in the memory bank. But unlike other people who hear it once and they remember it, you're going to have a much harder challenge with that.
Going back to the memory problem, I asked my doctor, I said, at my age, I have epilepsy and I have a brain tumor. Which one of those is causing me to lose my memory? And he told me all of them. I said, well, that's a diagnosis I could have given. But what I was looking for is which one of those is causing me the most loss of memory?
Well, my guess is it's probably a little bit more on the epilepsy side, but I don't know where your brain tumor is either. I mean, if you have a brain tumor back here that really doesn't have a lot of involvement in your memory circuits, then, you know, it's not necessarily creating a significant part of that issue. So part of it is tumor type, tumor location. But yeah, with seizures, we know that frequently these short-term memory circuits get involved. So.
Maybe just a recommendation to the lady who asked, like, what time Elaine's coming over, and then 2 minutes later, what time Elaine's coming over. If she writes it down and leaves it on a sticky note or something, sometimes that triggers another area in the brain. Oh, wait a minute, I wrote that down. Let me go look at my note.
Right. Yeah, and you'll have psychologists and other therapists who will give you lots of little ways that can help you out, because if not everything's working correctly, you have to have these little shortcuts as much as you can get them.
These are the last 10 minutes, just so everyone knows.
Back to your favorite little crew over here. What is the number of epileptic patients that go back to their driving privileges? Because I want to go back to driving.
Yeah.
So how many actually do, like what is the estimation of people who have epilepsy that eventually do go back? Is it 50, 20? I'm just looking for an estimation here.
Yeah, well, the big numbers, I mean, we talk about epilepsy in the United States being anywhere from 2.2 million, and some say it's as high as 4 million. We would expect about half to two-thirds being controlled, which means, depending on what number you're looking in the denominator, will give you that issue. Any patient who walks in the door, and they're new to me, I'm going to keep those numbers in my mind that probably, you know, two-thirds of patients with epilepsy should get fairly good seizure control on medical therapy or one of the other treatment options. I know that's not the best answer to try to give you a number to grasp. The bigger problem is individually, if you look at yourself and you failed 2 medications or you failed 3 medications, unfortunately, that then puts you in that category of being medically refractory, which means you're going to have a tough time getting to that seizure-free point for 6 months to operate a motor vehicle. Remember that 50% of the people with epilepsy become seizure-free on their first drug, and they stay that way. It's once you start having to go to drug 2 and drug 3, we know that you've got a real problem then, that your likelihood of driving is much lower than those we've referred to earlier.
Hi, I have a question. I was wondering, like, I started having seizures 5 years ago, but I've always been like an honor roll student, never had a problem reading or anything like that. But now I noticed that my attention span is really short. And of course, memory loss is an issue, but I find like I can see a word, I can see a number, but if I go to print it or say it, it's the total opposite of what's there. Has there been any research to study if epilepsy affects learning, or does it cause like forms of dyslexia? Has any research been done about that?
Yes, there's lots of research. Again, answering this question is a bit problematic because remember, every brain is different. Where your problem is, what your seizures look like, what drugs you're on, those are all things that come into play here. We do know that seizures, and depending on what circuitry in the brain they're involving, can cause problems with your memory, your reading capability, your ability to do this task or that task. And so it's a very individualized issue, but I wouldn't be surprised if you're still having seizures that that's a challenge. And also, depending on what medication, that can even become more of a challenge sometimes.
I was wondering, do you know where we're at as far as approvals for the NeuroPace stimulator?
Yes, I do. NeuroPace just got approved Thursday. Yeah. So it's going to be only available at limited centers with people who are there who've had experience with it initially, because for those of you who've had any interaction with NeuroPace or understood what the trials consisted of, it's not a straightforward, oh, take this in the morning and call me tomorrow and see how you're doing. You're talking about brain surgery, implanting a computer in your skull. You have to have electrodes in the right place, and you have to train the computer how it recognizes seizures and sends a current back to that area. Remember, this is a device that's mainly used for people who have uncontrolled epilepsy, who are not typically a good surgical candidate. A good epilepsy surgery candidate is someone who has seizures coming from one specific area of the brain. You can remove it and not create a big problem. But there are people who have seizures coming from both sides. You can't remove both sides of the brain. Or they have people where you have seizures coming from a part of the brain that if you remove it, you're going to create a big problem, like difficulty with language or weakness or something like that. So patients who would be considered candidates for NeuroPace have to fall in that smaller population.
I just want to make one comment. People are talking about how they have memory problems and stuff. What I found on the computer is memory tests, and it's the same test that you get when we were at Henry Ford. The shapes, numbers, words, and stuff. And I do that every day and night to help my memory a lot, and it's gotten a lot better. So I recommend it to a lot of people.
Yeah, I mean, you want to, just like, and again, I'm not saying epilepsy is Alzheimer's, but when you think of the network, if you keep challenging it and making it work, hopefully it will improve. So thanks for that suggestion.
I don't want to send us out here in a big political fight and have anybody start throwing chairs at me, but my question is, if the Affordable Care Act comes out as has been proposed, how will that affect what's being done in regard to epilepsy and the medications and et cetera?
Well, I'm sure that I can't answer that to the degree that it may. What you could say is, with the new Affordable Care Act, there are patients who previously couldn't get insurance because they had a pre-existing condition that now can. So from an epilepsy standpoint, I think that's a very big plus. Can you read that?
Yes, it's 5 minutes.
5 minutes left, okay. On the other hand, though, as you all know, our government has been cutting some of the funding for various issues such as research for epilepsy. The NIH budget is quite flat, so you have researchers who are very interested in doing more work in epilepsy, but they're going to have a lot harder time getting funded. And I'm sure there's like 27 other components of the Affordable Care Act and epilepsy that we could talk about. My major concern, and this is where we always run into problems with the government and with healthcare insurers, is they tend to throw epilepsy in this bucket like high blood pressure or something else, where they say, well, you have to try drug 1 and 2 before we'll let you have 3. Well, they really have no clue of the variability of the different types of epilepsy syndromes and the indications and what works and what doesn't work, and that's a concern. So we need to continue to push that envelope where that ability to make a decision on choosing medication is left between you and your physician and not the federal government.
Is there a safe way, if you feel yourself having maybe some staring episodes or feeling funny, to do something with your medication to prevent a seizure taking place?
I was told, thank you, this was my last question, so I just wanted to, if you feel a seizure coming on, there's a couple things you potentially could do. I mean, one, if you're having seizures because you're not getting your medications on time, of course, get your medications on time. When we talk about seizure interventions or emergencies, there are a few things one can potentially do. Some people have been given lorazepam or Ativan, a pill that you can stick under your tongue or swallow when you feel a seizure coming on. Some people get what are called clonazepam wafers, which is a little wafer that will dissolve quickly in the mouth, which could also stop seizures. And I'm sure all of you have heard about Diastat, which is Valium or diazepam that, unfortunately, the mode of administration is not very popular because it has to be given like a suppository. Those are all things you could do to try to intervene acutely with seizures. There are a few other things that are coming out that are in the study mode right now, where either we're talking about an injection into a muscle, but what's looking more popular are little sprays that go into the nose or into the mouth when you feel a seizure coming on. The problem with that is all these medications that work can make you a little tired. You would love to have a medication that works and then you just get on with your day and it's not an issue. Unfortunately, there's a little trade-off with using that. Am I answering the question though? Yeah. So everybody's looking to have those options. The one thing you have to be careful of when we talk about these benzodiazepines like lorazepam or diazepam, you don't want children to have the ability to grab these medications, because if you take too much of any of this medication, you can stop your breathing. So you want to be sure that those pills aren't left out on the counter. You also want to be sure that you're not in a position where you're confused and you're taking 6 of them at once because you didn't realize what you were doing. So there are options, but you just need to be careful with them.
Thank you. And Dr. Smith, thank you for being here and for taking so many questions and doing such a good job with them. So,
thank you.